guys hear me? On? All right. So I want to welcome everybody to Community Rounds. No, Community Medical School. Community Rounds is something else I do. And so first I have to give you a couple orders of business here. So my name is Steve Leffler. Right now my title is I'm the Chief Population Health and Quality Officer for the UVM Health Network. And I'm the incoming president for the UVM Medical Center, which will start June 1st. Thank you. Thank you. I'm also an emergency physician. I've been practicing for 25 years. I've worked with Dr. Weimersheimer, helped teach him at one point. He's far surpassed that. And so I'm really happy that he's here with us. It's important after this session you fill out your evaluation forms. They do read them. They take that information, decide what they're going to do for other sessions and how to make them better. So please fill out the evaluation form, and there'll be someone at the back to collect them. If you have questions, please save them to the end, and Dr. Weimersheimer said he'd have a great answer for all of them. So save them to the end. And now I'm going to shift, and I'm going to give a brief introduction. If I did everything that was on Dr. Weimersheimer's CV, it would take up the rest of the session. So I can't do that. But he is a professor of surgery and emergency medicine at the UVM College of Medicine. He graduated from medical school here at UVM in '95. He received the John Davis Award for this Department of Surgery in 2015, and he has the Peter Weimersheimer Professorship of Surgery and Emergency Medicine starting in 2013. So a huge honor, the only endowed professorship in the emergency department. So a really big deal. He has a ton of publications. He lectures nationally, actually all over the world on ultrasound. He's an ultrasound world expert we're so lucky to have here. And I can say without question, he's actually the finest emergency physician I've ever worked with. He's amazing. He's a great doctor. He takes great care of his patients. When I was running the department, we used to get satisfaction surveys, and they would give the grades for the doctor. And one person got 100% satisfaction every time. It was Dr. Weimersheimer. So thank you, Peter. It's an honor to introduce you.
Yeah.
Okay. Sorry about that.
This is good? Are we good? We're good. Okay, cool. All right. Well, thank you. Really honored to be here. Thanks for coming. And I was asked to talk about how to access our healthcare system, right? The talk is about whether you should be going to an emergency department or an urgent care or the primary care for an acute intake. And that wouldn't even be a discussion if it wasn't for the fact that in our country, right now our emergency system is fraying, right? We have a stressed system. We have patients going more and more often to the emergency department. Over the past 2 decades, we've gone from getting 90 million visits a year in our country annually to 140 million annually in 2 decades. And at the same time, the emergency department numbers have decreased from around 5,000 to 4,000. So the net effect of this is now our emergency departments are more crowded. There's longer wait times. There's a real question of that, how that affects patient care, and is that good patient care? And I'm going to try and talk about tonight. And it's a hard question to answer, whether this is the right thing to do or not, right? Who should go to the emergency department? Are we getting all the right people? So some people are going elsewhere, and how do you make that distinction, and how do you educate people on what the correct choice is? And that's the answer I'll try and talk about today. And here's the reason why it's so difficult. This is Mr. Smith. He's 45 years old. He's healthy. He's never had a medical problem in his life, but about a week ago, he started having chest pain. Intermittent, didn't think much of it. Maybe it was when he was shoveling snow. But it gets worse over the week. And towards the end of the week, it's really bothersome. It's bothersome when he breathes, it bothers him when he moves, and finally, after work on a Friday evening, he's nervous, he's gonna go get checked out. So he comes to the emergency department, and he has chest pain. And for anybody who comes into the emergency department, we do a quick set of vital signs. We check blood pressure, heart rate, temperature, all the things we measure for everyone, and his are normal. And for chest pain, we also do an EKG, an electrical tracing of cardiac activity. Is it normal or not? Or something that's concerning about heart disease? His is normal. And then in his case, it's been going on for a while, so we send off a lab called a troponin. It's a biomarker for heart muscle damage. And it's a way that we use to measure someone having acute cardiac injury. And his is negative. So he gets some ibuprofen, and he gets discharged home, and he does fantastic, fantastic. So same day, Mr. Jones comes in. He's 52. He's also incredibly healthy. As a matter of fact, he's coming to us from the gym. He was working out, and he wound up getting a little bit of chest pain, maybe lasting 10 minutes. He does note that during that time he didn't feel right, whatever that means. But by the time he sees us, he's absolutely pain-free. He has normal vital signs. His blood pressure and heart rate are normal. He gets an EKG. That's normal. And we do one of those troponins, and it's normal. And so in any medical system, there's really good paradigm now that if you have chest pain which went away, it doesn't sound like much, you had an EKG which is normal, exam is normal, eat that once, that's probably someone who gets an outpatient. That's what we do. But in this emergency doctor, right inside, normal. So that's the issue, is how do you talk about and how do you sort out who, from whatever symptom they have, has the disease that you're worried about. So I all want you to think about a healthcare system in crisis. You ready to do that? So think about how there's a population that's incredibly mobile, right? People aren't staying in their towns anywhere. They're moving around for jobs, for different living situations, right? And so by doing that, they start losing access to a regular primary care doctor that they've had for their early lives. They're also getting jobs that involve commuting, long work days, and days which don't allow them to access a primary care system regularly, right? So as a result, they wind up using the emergency department as their access point. In addition, some patients have insurance, but some of those insurance policies actually pay more when you go to the ER than when you go someplace else. And others are underinsured or have no insurance. And so the emergency department becomes their home for medical care. That's where they can go. Does this sound familiar? Right? This is the problem. Well, I've just described healthcare in 1951. So one of the things about how we're talking about healthcare in a crisis and how do you access cost and quality and standards of care and what should you or should you not do for each patient is that this is not a new problem. This is the same problem that's been happening for over 70 years. 70 years. And so as we talk about that in our modern community, politically and in the press and the public, we're talking about a problem that if they couldn't solve this problem in 70 years, boy, this is a complicated question, and it's a really controversial topic of what decisions you're going to make, right? And so for all of us in this room as a community or society, you're balancing budget and regulation of testing and access, and ultimately global outcomes on patients, right? That's how we assess how healthcare is working, right? And the United States has a very expensive healthcare system with not great metrics to show for it relative to other systems. But for all of us in this room as individuals, for you, for me, the question that I want to know, and I think you want to know, is when you're having a condition which is urgent from an injury or an illness, where's the right place to go? And if you make the right choice, that's probably optimal for care, and if you make the wrong choice, potentially that's a worse outcome. So how do you make that decision? And that's the decision we're trying to talk about today. So before I go through all that, I have to make a couple of disclosures. Number one, I'm not a health economist. I'm not going to talk about the relative cost of going to an emergency department versus an urgent care or primary care system and all the reasons that some tests cost more than others and all that stuff. That's not my purvey. I'm also not an expert on healthcare policy. No degrees with any FUDs behind it. So I'm not going to talk about the relative merits of our current system, where emphasis should be placed to try and change it so it's more efficient and more effective, or how it compares to other global systems. That's not my purvey. What I am is an emergency physician. Right? I've trained in emergency medicine. I've been working in tertiary care medical centers and community hospitals for over a quarter century. And so I do feel like I can comment about what modern emergency medicine currently is as an access point for all of you. And I can also talk about how to think about when or not to go to an emergency department versus another access point and why that's important in our current system with technology. And notice I said the word modern, right? Because you have to admit, for me, it was a little disheartening when I was realizing that the issues that I'm reading about in the paper this morning have been the same issues that have been happening in 1950. That's really demoralizing. But the one thing that's really good about emergency access and emergency care is that in 1950, there was no EMS system, there was no pre-hospital care, There were no emergency doctors. It was a very haphazard system for how people were cared for who were in crisis. And the one thing that has happened over this period of time is that there now is a robust pre-hospital system, and there are now providers who have trained specifically in emergency medicine who are there that when somebody comes in acutely, they're gifted at the management of those patients. So, of course, right, this is not new that people have accidents and get sick. As long as there have been people, right, there's been illness and accidents. And the difference is over time that we have now in more modern medicine, we have technology, we have treatments, we have interventions that change outcomes which weren't available even 40, 50 years ago, right? So now there's more and more pressure to get a diagnosis and do a treatment because this can make a difference in life. And for a long time in medical practice, I think leeches were probably an effective way to treat some things, but they're not the most robust cure for certain other diseases. Unfortunately or fortunately, in the military, there was always pressure on how to manage accident well. And there was early pressure and early awareness of how to change medical practice based on the need to treat a lot of injured soldiers. So this was in the 1700s. This is a physician for Napoleon who was credited with inventing or creating a field triage system, and he actually invented and created battlefield ambulances, recognizing that if you got to someone who's injured and maimed quickly and they could survive, their chance of survival was better. In medicine, there wasn't that pressure, right? There was no pressure in the medical world for a long time to do anything different in how we cared for people because we didn't necessarily have anything we could do differently in how to care for them, right, in terms of changing outcomes, right? So the model has been forever the general practitioner, right? The jack of all trades would visit patients in their homes, would see them in the office, would see them in the hospital and take care of them in a longitudinal way when they got sicker. Depending if they were urban or rural or what their practice setting was, they would be a jack of all trades who could do minor surgeries, they would deliver babies. There were specialists, but specialists were mostly in urban centers with higher populations and they wouldn't see patients primarily. So that was the world. And that world was effective until all of a sudden we had more things that we could do to fix people. And all this changed really after the Second World War. So we'll go through a little bit of medical history of emergency medicine. Second World War there was a booming economy. It was a time of incredible optimism. People moved all over the country for new jobs, for new ways of life. And the interstate highway was being built. It was an incredible time. People now lived in different places. They had different jobs, longer commutes. It was harder to see a primary care doc that would use the hospital and emergency department more for access. And as you can expect, since everyone's now in a car driving around, a lot more accident and injury is starting to flood hospitals who typically didn't have that much volume of accident and injury. There were EMS systems some places, but for the most part it was really haphazard, so if you got sick or hurt, you'd have to figure out some way to get to a hospital. That included calling your local funeral home director and seeing if they bring the ambulance, and if you're really sick, you can just ask them to idle it in the car or the parking lot or something, right? It was also a time of technological change, right? There was a lot of technological developments as a result of the Second World War. And that had two effects on medical care. The first is that the machines are big and they're expensive, they don't fit into a black bag, which means that if you want to get these tests, you have to go where they're located, which is a hospital. So the hospital became a center of testing because there were new tests that you can get. And so primary care GPs or specialists would refer patients to the hospital for needed tests. And the second aspect of this is that there's limitations to how good we are in our clinical and historical skill set with patients, and the tests now existed to make our diagnosis of disease more accurate. So now, sometimes these tests would diagnose a condition which, if it was treated effectively, would be life-saving versus clinical exam alone, which may have a delayed diagnosis and a different outcome. So not only do the hospitals have the machines, they actually had machines which could save your life. So people started going to the hospital for testing. Insurance industry took off in the 40s and early 50s. A lot of people started having insurance policies, which was really cool. They mostly paid for emergency care and hospital care and not primary care. So again, there's another background pressure of how to take care of patients in the hospital because there's more reimbursement there for the patient themselves. So ultimately what this means is that there was more and more use of emergency rooms in hospitals who were neither prepared for it by infrastructure or by staff. And this was our world. This is the world of in the 50s. And hospitals had emergency rooms. They were often a room or a couple of rooms, typically in the basement. And the staffing was really haphazard, and I guess bluntly, it was relatively poor. At county academic medical centers, most of the staffing was with an intern, so a first-year resident, or a second-year resident. So that's crazy, right? You're talking about the most vulnerable of the population, the sickest of the sick. They come in, they're cared for by a recent graduate from medical school who has the least amount of training of anybody in the medical center. That was a norm. In private hospitals, it was a little better because there actually were specially trained people asked to work in the emergency department, but they were kind of asked or forced, recruited to work in, and a lot of people weren't that happy about it. And that could be a specialist from any medical specialty. It could be a moonlighter. It could be a medical student. And there was no requirement that they had any skill at acute care or resuscitation. So the public actually was pretty aware that when they came in, sometimes it would be cared for people who seemed to have no idea what they were doing. Right? That was our background emergency system. So in the early 60s, there were some docs who really were interested in and recognized that we should have a system in our country where when somebody is sick or injured, they should see somebody who is dedicated to taking care of them. And in 1961, the first group of physicians contracted with the Alexandria, Virginia Hospital to form an emergency group that staffed their emergency room 24/7, 365. It was the first time that happened. And that started catching on. That was the Alexandria plan. And all over the country, medical centers which were being stressed started realizing this maybe is the way to go. And ultimately, there were a bunch of physicians who really believed that emergency care is the right thing for our country and formed the College of Emergency Physicians. And as a specialty, this is for us who practice emergency medicine, this is pretty profound. This is a group of doctors who really believed in social justice. They believed that anybody who came into a hospital, no matter of their socioeconomic status, their ability to pay, whatever the issue was, that they should get good health care as they went through the door for an acute problem. And that's really how it started. But there were three things in the country which changed how our country approached emergency care and emergency medicine. And the first was in 1963, right? This is when the president of our country, John Kennedy, got shot, a headshot. He's transported in his limousine to Parkland Hospital in Dallas, which it currently is one of the premier trauma centers in our country, in the world. But at that time, he was cared for in this room by a second-year surgery resident and a nurse with very little experience. So again, crazy. The populace was aware of this, but the most powerful man in our country, one of the most powerful men in the world, has a critical life-threatening injury, and he's managed by a trainee who has little more than 1 year of experience. That's our medical system. And veterans were coming back from Vietnam, appalled that when they got back to their hometowns, that when they went for emergency care, or they took their loved ones for emergency care, they were getting worse care in America than they were getting in a battlefield jungle hospital in Vietnam. It was worse care. And they're like, how can this be? And finally, the county hospitals, with the new change in population and growth, were getting overrun. County Hospital USC in Los Angeles, by the late 50s, was seeing 1,000 patients a day with no infrastructure and no staffing. Right? It was not a good model. And so as a result, finally, there was a lot of pressure and a lot of folks got together, and this white paper got published, which was really a roadmap of how to develop emergency care in this country, which means get a pre-hospital system and get an emergency system where you have providers dedicated to emergency care. So that's when it started. And things started moving relatively quickly at that point in time. By 1971, there actually was a residency in Cincinnati. So what a residency means for training is now medical school graduates were being trained specifically at the University of Cincinnati on how to be emergency physicians. That's all they were going to do, and they were getting trained on resuscitation and critical care. And you may be thinking to yourself, like, why Cincinnati? Like, why that place of all the places in the country? Well, in the late 60s, 68, 69, there were race riots in Cincinnati, and one of the issues in the race riots was the poor care that the lower socioeconomic folks were getting at the Cincinnati hospital, and they rioted and stormed the hospital and demanded better care. And out of that came a residency. Same thing, USC was the first place to have a department and another residency in the same year because of the pressure of all the patients coming. So this went on, and places started to evolve. And ultimately, in the mid-'70s, the College of Emergency Physicians applied to be that emergency medicine should be a specialty. And what a specialty means is they can start setting regulations of what does it mean to practice emergency medicine versus internal medicine or pediatrics or family medicine. What are the standards we should be setting? And you would think that given all the stuff that's happening in terms of access crisis, that this is a no-brainer. And maybe this is a harbinger of how hard it has been, even currently, to change our practice and our patterns, is that this was rejected by the other specialties. They wanted no part of this. Emergency medicine is not worthy of medical specialty status. So ultimately, it became a conjoined board, which means that other specialties got to have their say in what emergency care should be or should not be. But that was good because now there was actually some standards and some way to regulate how people were being trained in a cogent way. But probably the biggest sea change that happened and how it affects us now in our modern world was in the mid-'80s with the enactment of EMTALA. So this is the Emergency Medicine Treatment and Labor Act. And this is a really important law that was passed by our Congress for medical care. The reason this got passed that in the 70s and 80s, private hospitals stopped treating uninsured. And so by the time this law was passed, about 70% of patients with no insurance, when they went to a private hospital, were turned away or transferred elsewhere. And there, you can imagine there were a lot of horror stories of people who actually died because they weren't treated, including one famous case of a patient who died in the parking lot, lying down on the asphalt in front of the doors of a private emergency room. All right, that was the world. And so this law changed that. And this law changed how people would think about accessing the hospital, because now it was a mandate that any patient can go to any single hospital, and by law, they needed to get screened for medical disease, or for sickness and accident. And they couldn't be transferred any place else unless they were stabilized, which means they needed to get treated with interventions, they might need testing, whatever it took to make sure that patient was healthy and stable enough to transfer was required. And so that meant that for you, as a member of our country, you can go any place you wear to get care regardless of ability to pay. Really important. And you can imagine then all of a sudden now the emergency department is getting flooded with patients, and more patients are coming. And by 1989, we have our own specialty board. Think about that. There are a few of you in the room who are older than 30. I'm older than 30. That's only 30 years ago that finally there was some decision that emergency medicine should exist as a specialty. And that was really important because now there were standards of care. Now you could show up in an emergency department and the trainee who had graduated from an ABEM program was skilled at taking care of you when you showed up. And that means skilled at resuscitation, at critical airway management, at critical care, at making acute, difficult diagnosis of life-threatening versus non-life-threatening disease and managing it well. That's what we do. That's our job. So how does this affect you? What does this mean in terms of what you should be doing? Right? The ideal world, again, is that paradigm of a GP and a patient. I mean, what a great relationship where it's a longitudinal care. There's a relationship in terms of medical issues, medical preferences, medications, adjusting things as they change in a way which are good for how everyone is managed, and sometimes involving the hospital. And then now with the advent of emergency departments in emergency medicine, sometimes referring for acute care for life-threatening conditions or to a specialist. But the reality is that's not how our world works, right? Sometimes you can't get in when it's appropriate, and sometimes the issues that you may be having are more acute than you should go and see a primary care provider, and that's when going directly to the emergency department makes a sense. And of course now, there's crowded emergency departments, there's difficult with primary care access, and what evolves in the middle is the urgent care model. Another access point that for somebody who's not that sick but needs more immediate care than they can get in terms of a primary care appointment, maybe that's the place to go. And ultimately, the question is, how do you choose which one, where do you go, right? How do you make that choice? And I'd like to tell you I can make you lists of things that should prompt you to go one place or the other, but just that's not how it works. So in general, longitudinal care, things that are more chronic, things that have been stable, maybe changing slowly, involving medication changes, low-grade changes in symptoms, that's great for primary care, right? And the converse is when things are really acute, especially when they're perceived or are life-threatening. Emergency room, we're the specialists of life-threatening conditions. That's what we do. That's our job, right? And so you have to try and balance that out. One of the reasons we're specialists at life-threatening, as technology has evolved and has been better in terms of making the diagnosis of a lot of significant critical diseases, most of that technology is in the hospital still, right? I think some of the urgent cares sometimes will have access to a CT scanner for a while or ultrasound, but that's at limited hours. We have that and other things 24/7, and that's the nature of hospital-based medicine. And ultimately, since we are staffed 24/7 and we have a lot of technology and a lot of equipment to do emergent management, we're more expensive. So if you're paying for this, it's more expensive to see us, and that's our current economic model in the world. Make sense? So when you come and see us, right, you're coming ideally because there's some life-threatening or some condition which seems really urgent or emergent. And what you get is you get providers who are trained in resuscitation, trained in critical access like we talked about. You get the ability to have a lot of pharmacology and resuscitative equipment, airway management, all that. We have all different diagnostic testing available, including the ability now to take an ultrasound at the bedside and make a decision within minutes of arrival about what's causing somebody to have a medical condition or a traumatic injury. And finally, we also are a gateway to access specialists who, if somebody has something which requires emergent intervention from a specialty point of view, we can transfer access in our shop if that's what we have. And still in the background is, when do you go? What's an emergency? Right? This is risk management. This is you as a person in the community saying, I think what I have is really serious, or have an injury which is more obviously serious or not. And then it's us, when we assess you, of making a decision about how emergent that is as well in terms of what we do. And this is hard. This is hard in terms of understanding how to translate a symptom into a risk. In general, the more mild symptoms have higher risk for people at the extremes of age, who have problems with the immune system, who have chronic disease. But in reality, anything can be serious and anything can be not serious, and it's hard to quantify those. And that's what the issue, as we're trying to parse out where to go for different symptoms, that gets difficult. And I'm going to run through things we think about and how that works for us. Right, I already talked about chest pain. That's a relatively high-risk thing, right? I think everyone realizes that when you're born, your heart starts beating, and when you die, it stops. So having something involving chest pain and maybe involving your heart is kind of an overwhelming thing. And we're good at making that diagnosis. And no matter where you go, oftentimes one of the things that happens initially is that you get an EKG, a tracing of heart. And if you're someplace where it's possible, when you see changes on the EKG that are life-threatening and portend having a heart attack, that needs immediate treatment or immediate management. Most patients are going to have a normal EKG, but as I talked about with that case of dissection, that doesn't mean that it's not a life-threatening condition, it's just not a heart attack. And so we still need to parse it out. And having the ability to do advanced technology for patients who have some of those diseases is really important. Similar to chest pain, people get palpitations. I can tell you I got palpitations sitting here waiting to talk. It happens, right? Right? And most of the time, they're fine. But sometimes palpitations are prolonged. They're associated with some chest pressure or difficulty breathing, or the heart's racing for a long time. And that gets a little concerning. And some of the palpitations that people get or racing heart are pretty benign in general for a couple days, but then after that, they start causing blood clots and cause risk of a stroke. So we have expertise in making that decision about whether you should be on stroke medication for palpitations that you have. Most people have colds once in a while and can have issues with breathing. Some people have asthma, bronchitis, and primary care, urgent care is often fine for milder flares, but flares can change and flares can be much more serious and people have really hard time breathing, and we're experts at airway management and resuscitation of airways, right? We have all sorts of devices, high flow nasal cannula, BiPAP, CPAP, and we're experts at putting in breathing tubes if we need to do that. That's what we do for our job. Clearly, blood coming out any place that it's not supposed to be is bad, right? Whether you're puking blood, pooping blood, peeing blood, have a nosebleed that's not stopping, we stop it. We try and help stop it. A lot of folks have allergic reactions from all sorts of stuff, and usually a little Benadryl ice might help, but people can progress to anaphylaxis really quickly. So we see a lot of patients, appropriately, who who are really nervous about how fast some swelling or breathing changes or difficulty swallowing is changing, and they come someplace where if it truly is progressing that quickly, they can get help quickly and get managed, because these can really rapidly change. Unfortunately, a lot of folks have headaches, and primary care does a great job at managing chronic headaches with paradigms at home. And sometimes we see patients who have headaches that exceed what that management does, and we take care of them well with our own pharmacology. But certainly, there's people who will suddenly get a headache out of the blue, never had one before. What does that mean? Especially if it's associated with a fever or some change in how you're perceiving the world or some neurological symptoms. That could be life-threatening quickly, and so we have the technology to investigate that. Unfortunately, we also see a lot of patients who have strokes, right? Focal weakness, difficulty with speech, something which is different in how they're functioning. And there's a lot of controversy now about what to do with the milder version of strokes, or something called a TIA, where somebody has a stroke for a brief period or stroke-like symptoms, and then it gets better. But there's very little controversy now about going into people who have denser strokes. There's a small subset of patients who have this, who we can go and get clots out of their artery, and they do great. And the only way that gets treated is by having access to machines that can make that distinction about whether they'll benefit or be harmed by this type of procedure. And it works great for those patients who can benefit. Belly pain, a lot of people get belly pain. I had a bad meal the other night. But sudden belly pain, especially when it's focal, can be a harbinger of badness. How do you know if you haven't had it before? And interesting about abdominal pain, its degree of severity is proportional to age. So an 80-year-old with sudden severe abdominal pain, 80% mortality if untreated and unevaluated versus 50 or 60 or so. It's a so significant disease, and oftentimes presents in a little bit of a less straightforward manner. You all have backs, right? You've all had back pain. You can't have a back and not have back pain, and usually, again, we will see some patients who have flares. That can happen at an urgent care model or primary care model. But sometimes people have severe unprovoked pain out of the blue, and what does that mean? And how do you know that it's not going to be a harbinger of bad outcome? And unfortunately, the testing for that usually is pretty advanced, usually involving an MRI if it's needed. Fevers and rash, a dime a dozen. Usually get better with Tylenol and Benadryl, except when it's meningitis. So again, somebody who gets sick and has a new fever, new rash, unsure what it is, probably want to come to us versus someplace else. Same thing with leg pain and swelling. A lot of people get low-grade leg infections called the cellulitis, evaluated easily in a community setting, but sometimes that's fast progressing, very painful, harbinger of a more significant infection or a blood clot, risk of a blood clot to the lung. We take care of those. And we see lots of patients who have fainted for no reason, who have fallen with injury or not, or who become so debilitated they can't get out of their bed and they can't function. And that's people we take care of as well. At the other extremes of age, we see a lot of infants who are awesome except when they're not. And when they stop eating and drinking and stop acting like they're happy, or they cry all the time, that's a really high-risk presentation, and we should be seeing them. And finally, we're the centers of accident and injury, right? And certainly minor bumps and bruises, small lacerations, absolutely amenable to urgent care or primary evaluation. But we see a lot of patients who have bones that are out of place, lacerations which are complex and bleeding a lot, and worse injury as well. And we're good at taking care of them. We also can do sedation, which means people don't have to feel us reduce their bones, or we can do regional anesthesia, same type of thing. So that was a quick run through some of my reasons that you should be coming. And you probably were thinking, or I assume you might have been thinking that, I don't know, sometimes I've had all this stuff and I haven't gone anywhere. All right, and that's the issue. And so there's a concept of prudent layperson where you in the community have a symptom or have something happen and you make a decision of your risk and you show up in our shop or someplace else because you think that's the right place to go based on your decision. And there's no harm when we see a lot of patients, and one of the issues with emergency department care now is a lot of patients who come to us ultimately don't have the severe disease. That's fine, but how do you sort those patients out? Right? And here's some other cases. 38-year-old woman, healthy, she develops this excruciating pain in her abdomen for 2 hours, just not going away. She's trying to ride it out. She finally comes to us. She gets an EKG because, I don't know, sometimes upper abdominal pain is heart disease. That's normal. And her doctor eventually decides that he's going to try some oral antacid. So she gets a slug of Mylanta, and guess what? Pain goes away. It's awesome, right? She's better. So she gets to go home, gets put on oral antacids, follows up with a primary care provider. Same day, another 38-year-old woman comes in. She's got belly pain. It's a little bit different, also never had it before. And she's not in that much distress. She's not writhing around, but ultimately when she lies down, her pain gets worse. Something about that isn't right. And so her doctor is able to take a system right into a room and take a look at her belly because something's wrong. And this is an ultrasound of the belly. I mentioned before how in the ultrasound world, black is fluid. That's black inside an abdomen. That's blood. And here, this donut-like structure, that's an ectopic pregnancy. That's a pregnancy outside of her uterus. So this woman is bleeding to death, didn't know she was pregnant, and she goes to the operating room in half an hour. She does well. But again, by her symptoms, you wouldn't know that. This is a 65-year-old gentleman. 2 years ago, he had flank pain, got a CAT scan, had a kidney stone, did great. Did fantastic. And now he had pain at home. It was pretty severe. He vomited once, so he said, I better get to the emergency department because I remember how bad this was. By the time he comes to see us, he's actually not that uncomfortable. We look at his CAT scan, confirm that nothing else was wrong with his belly before. He had some kidney stones. And he's able to go home after just receiving pills of pain medication and nausea medication. Happy as a clam, follows up with his urologist. In about a week, he does fine. This gentleman, 67 years old, he comes in with kidney pain as well. What he thinks is kidney pain because 25 years ago, he had a kidney stone. So he hasn't been imaged in 25 years, but it seems like what he had before. It seems about the same thing, except he looks a little pale when we look at him. Something's not quite right. So his doctor is able to take an ultrasound right away at the bedside and look at his kidney. And his kidneys look great. So he can't be having pain with normal kidneys. Doesn't work that way. So look someplace else, and right in the center of his belly is his descending aorta, which is the vessel from the heart to the body. And he has a ruptured aortic aneurysm, which often presents with flank pain, often causes blood in the urine, just like a kidney stone. So he goes to the operating room, does okay. And finally, this very nice 83-year-old woman, independent, has a walker. She's very vibrant, and she slips and falls, pushes her lifeline and comes in, gets to get checked out, and she's doing pretty well, right? She doesn't have a lot of pain. We give her some Tylenol, that helps. She has an x-ray, which is completely normal, and as soon as she's running around in the emergency department with her walker like a race car. And she has great home care. Her family's really supportive. She gets to go home. Another 70-year-old gentleman, he slips and falls and smacks his hip and his knee on a curb. He can't get up, calls EMS. He comes to see us. He has this, a fractured hip. And this is a big deal, right? This is an injury which causes a lot of morbidity. It's pretty tough, so he's devastated. So we set him up with orthopedic doctors to fix it, which is what we do. And he also has a doctor who can go ahead and put some regional anesthesia in that hip and make it fall asleep and not be painful. Right? So at least while he's there, his pain's under control and he can process the injury and that he's going to have a surgical repair. So I started this talk talking about the issue that our emergency departments are crowded. We have a lot of people accessing the emergency system. And the question is that the correct paradigm? Should there be different ways to access our healthcare system with urgent care or primary care? And how do you sort that out? And I think my goal here was to emphasize how difficult that is to decide what's the correct system, right? It's all about risk and about what the outcome is going to be, depending on what that risk is. And so one thing that's really important is that the expectations of patients coming into any one of the urgent care, primary care, or emergency settings is somewhat going to be different from what's available, right? So we see patients transferred from primary care, urgent care, who present in good faith, and then when they get there, they get an evaluation, and they're told, geez, what you have is a little concerning. I think you need to go to the emergency department. It's a little more that we're going to take care of. And conversely, we see a lot of patients who come into us who are really concerned about having a life-threatening or a life-damaging condition. And then when they come, there's a ton of people there, and they get triaged, and the triage may be that you need to wait. We have other people who are more sick, and right now they're going to have to get cared for first. And that can be tough with expectations, especially when, to the person presenting, their world is, I'm really sick and I have something wrong. And we have two jobs. My primary job is to identify of all the people coming in, who's the sick person? Who's the person that I need to resuscitate quickly, make the right decisions on in terms of diagnostics, and make an intervention that they have a good outcome. That's my job. That's what I do for my living, right? My second job, which is often much more fun, is I take care of everyone else. And sometimes that just involves a delay in care for somebody who is waiting for a while, but ultimately we take care of everyone and we're really good at it. And the goal is for this entire medical system, no matter where the access point, is that you go someplace where you get someone who does the right decisions, makes good care, and people have the best outcome possible. And it's not always the right outcome that you might imagine, but it's the best outcome possible. All right, so that was my survey of emergency medicine and access. Happy to take any questions. Go forward.
If you have a question, you can raise your hand. We'll bring a microphone to you.
How do you handle failures in your system? How do you learn from them? And is there a system in place to catalog all the failures and quantify them and learn from them?
So I guess failure is a broad word. So I think every system, every place has their QA system. We specifically have a system. Anybody who comes back in our shop within 72 hours is flagged for review. We have referrals. Any case that has any outcome which wasn't expected or something that was thought to be a learning point gets reviewed. And we do both private QA review, and we also do public sessions where we invite participation of all practitioners to come and learn from those cases. I think the reality is, as some of the cases I talked about today could be somewhat cryptic in making the right decision, we're all human. There's the idea of early closure, where somebody walks in the room and has the idea that this is the problem, and hears and sees what they want to hear, and doesn't pick up subtle cues that it's different. And this is a constant learning curve and a constant challenge to really manage people correctly. So yeah, so we have we have a very robust QA system, and I think that's really the best part of our group as a job, is that we review, and we're not shy about critiquing management and offering ways to correct that or to have that change. And the reality is, as I said, I've been practicing for a quarter century. I can tell you cases from when I first started that I've remembered and I've gone forward. This is how everyone shows up they're well trained, and we're intending to do the best job possible. And the reality is that in a busy world, in a world of a lot of volume, that we have to learn sometimes of being a little different how we perceived what we did in the past. If that makes sense.
Hi, my question, can you all hear, is we had a bad experience at an emergency room at a major hospital back in Arizona.
Yeah.
And the real problem there was the triage person wasn't trained apparently enough to recognize the seriousness of the injury.
Yeah.
And so hence we sat around for 6 hours with a broken femur.
Right.
Before we got to see a doctor. And so how well trained are the triage people, the persons at the...
I can't speak for other systems. The intent, certainly here, is that triage personnel go through a special course on how to triage and how to risk stratify and how to identify patients who have a serious illness or injury. There's certainly cases, I think, in every place there's going to be a case or description of someone who waited for a longer time than we thought was possible. And again, as we do QA of medical practice, we do QA of triage as well. And we have cases where we review how did somebody present, why did this presentation not trigger a certain type of response, and there are standards for triage, and so nurses are trained to actually use a list of signs and symptoms, and depending on the signs and symptoms, that does a classification. And this is part of humanity and human nature, that you can use lists and you can use standards, but there's an element of medicine which is still art. There's still this perception of walking in a room and saying, this person has something, I don't know what it is. And ultimately, the more you can have that codified in a practice training session and in QA, the more that changes how people get not unfortunately left to wait for a while. And one of the issues as there is a pressure to work on throughput and evaluation speed is that being in a waiting room for any period of time is hard, right? With no matter what, and certainly with missed injury, but the goal is to try and develop a system that there's little waiting and patients are evaluated quickly, and then there's less chance of any misses.
Dr. Weimersheimer, can you explain QA for the
Quality
audience?
assurance, I apologize. Quality assurance, excuse me.
Hi. Would you give a couple of examples of when it would be correct to go to an urgent care facility?
Sure. Again, a cough or cold, concerned about whether it's pneumonia or maybe having a breathing treatment to help out, injuries. Sometimes urgent care centers are also used for occupational health. Depends. They have their descriptions of that. So I think the idea is that anything which seems to be an urgent problem, more urgent that you're going to get into a primary care situation, but like just want to get checked out, don't feel that sick, they're available for. Most urgent cares have x-ray and they have blood tests. And so what you get is a provider who can do an assessment for what you're presenting and has a limited amount of testing capability. And so for something which like being flu-y and wanting to get assessed for that, that's a perfect scenario. So I think, again, it's an assessment of having something which is low grade, enough that you want someone to see and get checked out, and understanding that when you go to an urgent care, for most of them, it's going to be a clinical exam with maybe some intervention from that, maybe a blood test, and typically at most an x-ray as well. And if that's sufficient in the paradigm for some minor assessment, that's perfect. Low-grade lacerations, low-grade injuries without deformities that may need splinting, different than major lacerations that have tissue devitalization, bleeding, bony injuries that are deformed that are going to need to be reset. So that type of thing.
So I'm over here.
Hi.
I understand, for one thing, a lot of urgent cares don't even have a doctor. They're PAs, which is
Yes.
probably fine. But I know like one PA, he has an urgent care. He said someone came in with a fish hook in his eyelid, and he took that out and all this stuff. But on the other hand, I had a dog bite. I went to urgent care. But I also broke my arm and went to urgent care, and I thought it'd be faster because they'd x-ray it and they'd tell me whether it was sprained or really broken or whatever.
Right.
So wouldn't that be a case to go if you're not really sure and they're going to do certain things?
Sure. We have a lot of people with bony injuries, and they come in just to make sure and get an x-ray. And if there's no obvious deformity and the x-ray has a high likelihood of being normal, or for instance, ankle sprains. Right? Most people who sprain their ankle don't have a fracture. And most people sprain their ankle maybe just need an x-ray and then crutches and reassurance that this shit will get better. So I think the idea is that it's really, again, your suspicion of what the injury is and if it's going to need repair or fixing. So bony injuries, I think we see a lot of patients ourselves who come and saying, geez, I just wanted to check it out, make sure it's okay. And those patients who don't have a lot of deformity or loss of function, for the most part, those x-rays are normal. I think that's totally reasonable. And once in a while, you might make the choice and oops, you have a fracture and it's displaced enough that you're going to need to go to us, and we fix it. And we get patients transferred to us relatively often from urgent cares and from primary care who need to have that level of service, and that's fine. It's also a matter of discomfort. So some injuries are incredibly painful and more often a harbinger of worse injury, but it's hard to say. So yeah, totally appropriate.
Here's an example of urgent care.
Uh-oh.
I woke up with a very, very painful knee. Had not fallen, hadn't bumped into anything, didn't know where that would have come from, but it was very red and mean looking. And it was a holiday. It was early in the morning. My primary care doc was not there, and urgent care was just up the hill at Fanny Ellen. So I went up there at 8 o'clock. And I went because I didn't want it to get any worse. I was a medic in the Army. I mean, I was concerned. And sure enough, the docs, look at it and they said, yeah, it's a good thing you came because it could have gotten a lot worse, and it was cellulitis. So, even though it was kind of a not really difficult thing to diagnose, if I had not done anything, it would have been 2 more days and it would have gotten really mean.
Sure.
Hi, our family's had some really good experiences at the ER and good experiences at Fanny Allen Urgent Care, and then I've also had some unsuccessful ones. And I'm somebody who's reluctant to use the ER, thinking it's for really serious traumatic things, so we hesitate to go there if we don't have to, if Fanny Allen is, unless Fanny Allen's closed. But sometimes I've checked with my primary care provider and asked for guidance about here or there, when a family member had a gallbladder flare-up. And I think there's a lack of information out in the field with UVM's primary care centers around what you can really get taken care of where. Because the primary sent the family member to Fanny Allen on the weekend thinking they could get a gallbladder ultrasound, and they couldn't. Only Monday through Friday can you get that. And another family member got sent in case they had a blood clot in their calf on a weekend, and called ahead, and even the desk that answers the phone at Fanny Allen said, oh yes, we can see you, we can do an ultrasound. And we sat there for 3 hours before it was finally their turn, and then it was like, oh, we can't help you, you have to now go to the ER. So you check in and pay one place, and then you have to check in and pay another. And how do you, and I've put it on myself, like, oh, I should be smart enough to figure out where we should go or take someone, but I think there's a systems issue too when we're being sent by primary care offices to places where you guys can't end up providing the services.
Yeah, I
So
agree.
there's an education issue. Yeah.
There is an education issue. I think there are different urgent care centers in our community, and you can go online and see who the providers are, what they offer, and it's variable. And even the Fanny, it really should be advertised clearly that it's the imaging, the ultrasounds and CTs are really about 9 to 4, and after that it doesn't run. And so we've seen this a lot on our end where people have been referred in, never went there, and in good faith, and so it definitely is some better education and better public communication would be really helpful.
I even called ahead
that day,
and then I asked when I got to the desk
Right.
the registration person, and it wasn't until 3 hours later. It was like, oops.
Right. So clearly even the registration person needs to go to the website and get that information. So log in, pull the website up. Oh, this is what we're doing today. That's good. Ultimately, again, this is a cost and access issue. As you were saying, you're reluctant sometimes to come to our department. I can tell you, I love when I take care of patients who aren't sick. I mean, it's emotionally, it's a nice paradigm. But I think the notion for us is that we are a catchment area. We are a safety net for health as a health system, and ultimately, what I actually talk to patients a lot about when they're leaving in terms of having come and maybe they came for a reason which turned out to be less severe, is that glad you came, and if you feel worse, you come back, and that's what we're here for, and that's how we work. And fortunately or unfortunately, our healthcare system parses out access points in terms of what you get and how much it costs, and you have to, as a layperson, make that decision, and it's hard, to. Some people feel guilty that they came, and it's fine. That's what we're here for. And ideally, urgent care it should be almost everything should be all mingled and all quite a little bit of the same because it's hard to tell. So that's my spiel of happy to help. So.
Hello, I have a question for you,
okay.
Dr. Weimersheimer. One of the questions that we get a lot as staff members here at the College of Medicine is how best does the triage system work? Do you get a referral from your primary care? Should you go to urgent care and then they refer you to the ER? Is that a better solution than just arriving in the emergency department on your own, or is it based on when you arrive and who's more urgent than you or acute than you when you get there?
So the triage system where we are is you checking in and saying, here's what's going on, and somebody does an intake who's trained at triage and ultimately does an assessment and hopefully does that in a cogent manner where you're taken care of in the appropriate line. In terms of how should it work formally, you know, again, if in your judgment you're not sure what to do, certainly calling somebody and asking their opinion may be helpful. If you have a primary care provider who has access and can hear the story and make a decision with you, that's totally appropriate. It just depends on when this is happening, and you know, this still always goes back to your level of concern. If it's something that you're not sure and you feel like by your symptoms you have time to talk to somebody, and that's helpful. In terms of triage, triage is somebody meeting you, measuring vital signs, listening to your story, maybe doing a perfunctory exam, and taking all that information to make an assessment of what's going on. That's hard to do at home by yourself. It's hard to do on the phone with somebody. So certainly I have friends calling me up and saying, what should I do? And I carefully give them advice. I always say it's somebody else on the other end of the phone. But so that's, you know, again, it's a hard question. So certainly if something doesn't seem that sick, that urgent or that acute, and you feel like there's time to investigate, that's a perfect way to sort things out. Or, you know, again, if you go someplace and they say go someplace else, it's inconvenient, costs more money, but ultimately we all try and get people to the right place if we can. Right?
Are there other resources that people could receive assistance in triaging? I think that's one of the, you know, is there somebody else that they should be calling or could be calling if it's not their primary care?
You know, I think most times, for instance, if you called us, we would say, you know, by me talking on the phone to somebody, that's a high risk issue in terms of not getting it. You know, there's certainly if you go on the web, there's been all these paradigms for decades about doing almost an artificial intelligence where you can plunk in symptoms and keep on going, and it kind of spits out what it thinks you have. Those are they're relatively good, right? But everything has an error rate. So this is, again, when I talk about risk, what risk means is you think you have a symptom and how likely are you to be right, and how likely are you to make a decision that's not going to have a bad outcome. And so there's tons of resources that you can Google anything, and you get tons of information. Ultimately, I think personally I work in an environment where I'm a worst first thinker. So I think about the bad stuff first, and I'm happy when it's not bad, and that's okay.
I'd like to offer a suggestion. I'm not going to talk about a negative story because I think that brings bad energy to the room, but I didn't have a good experience in the ER room.
Yep.
But my suggestion is that people understand and know their doctors very well, because what happened to me was when I was being sent home for the third time with bone shattering and people saying in the emergency room, go see your primary physician, we can't handle this. I was called on the telephone by one of the doctors saying, how are you? We're looking at your charts and your x-rays right now, and this is not good. You need to stay here. And the emergency room was sending me home. And the next minute I looked up and the doctor was standing right in front of me. He was there as my advocate. I said, no, they're sending me home. And the next moment I'm on the phone with him and I look up and there he was. So my suggestion to people is, know your primary care doctor and know the doctors that are specialists that you're working with. They have telephone numbers and they're available 24/7.
Yep.
So if you're not getting the results you want in the emergency room, then call one of those doctors and they'll support you. Or they may not, but in my case, I was very fortunate.
Yeah, and I'd argue that the third time any place is not a charm, right? We have patients who we see, and I think in good faith make decisions, and ideally not the wrong decision, but coming back as we do our quality assurance process is for us a red flag if there's something that we need to treat differently and pick up differently. So.
My question is, how long ultrasound has been a key tool in emergency care?
Ultrasound. Why would I want to talk about that? So in emergency medicine, ultrasound has really been around for a couple decades. And for emergency training, it's been part of emergency medicine curriculum since 2004. So as part of it, it's actually a core requirement. So when somebody graduates from residency, they're required to be skilled at how to do bedside diagnosis and use it. And and there's variability in how that gets used by different providers. So it's been a long, emergency medicine is one of the specialties that recognize that this is really revolutionizing how we can take care of patients immediately at the bedside and make diagnostics much more rapidly. I can tell you that my first residency was in '96 when the ultrasound machine rolled out. We had no idea what to do with it. It was kind of fun, play with the buttons and start scanning people. So emergency medicine has definitely been one of the early adopters, and we're now involved from our division training the medical students. So what the world is going to look like is that now most medical schools are starting to adopt a 4-year ultrasound curriculum, because there's a difference in how you can listen and look and talk to somebody in terms of information and certainty of a diagnosis, that you can now go right at the bedside and add to that certainty, which is a really powerful tool. So I think the medical world in general, I'd say in the next decade, almost every specialty will have bedside ultrasound as their norm. It's really, I think, where it's headed.
Yeah, I have a question. Could you just address how you handle or triage mental health crises?
I think there's the two issues of mental health is whether there's an organic issue or in terms of physical issues as well as the mental health crisis itself. So we triage from both mental health and a medical point of view. And we have crisis workers, I'm fortunate to work in a hospital that has a psychiatric service and crisis workers available. Many of us, I moonlight in other hospitals where there's not much, and it's definitely more sparse. And so the intention is to do an intake and be respectful of what the issue is, and then get services to work with the patient in the emergency department to decide how to best manage that and where to go with that. So it's, oh, go on.
I heard something called first call.
Yes.
Is that still an option too?
Yep.
I had heard that. I don't know a lot about it, but I didn't know how that is handled or routed.
Well, when a patient's in the emergency department, especially if there's a current concern of risk, they're in our department, and we'll get first call to other crisis workers to come and meet with the patient in the department, and then make a decision about disposition and support and what's the right disposition from there. Again, have psychiatrists as well who are available to come down. So, yeah, it's a challenge. It's a challenge. We have a lot of patients in our emergency department with mental health issues, and there's a limited place in the state sometimes for placement. So the challenge is to try and take good care of them in our environment.
Do we have any other questions from the audience? All right, please join me in thanking Dr. Weimersheimer again.
Thanks very much.
We hope you'll join us in April for vaping, juuling, and e-cigarettes.